Hello, everyone. Good afternoon from here in India, where I am, and good morning, evening to everyone, wherever you're joining from. On behalf of several organizations, Sexual and Reproductive Health Matters, the South Asia Hub, and HENI, the Health Equity Network India, I'd like to welcome you to this webinar. I'm going to ask all the panelists to go on mute for a second so the videos work. So just to begin, I want to welcome you all to what is a very exciting discussion for us. My name is Sapna Desai. I work on women's health in Delhi, where I look at women's health issues, and something that has emerged over I would say, almost 2 decades now has been the focus, as we all know, on maternal health in our region across South Asia, with very little attention to women's other health issues through the life course. And alongside with colleagues, three of whom are here today on the panel, we've started the first sort of women's life course study in India, where we've been looking at the trends of unnecessary or unindicated hysterectomy, early hysterectomy across certain parts of India. And what really emerged quite strongly was that gynecologic morbidities and gynecologic health in general has been largely ignored, both in services as well as policies. So as we started having conversations, and largely through the SRHM South Asia Hub, as we started having conversations with colleagues in Pakistan, Bangladesh, Nepal, Sri Lanka, other parts of South Asia, we realized that there are very similar issues that our colleagues are facing across borders. So we wanted to use this opportunity really as a first coming together of people with similar contexts, similar interests, and similar challenges to start discussing what the issues are across countries, but also what we can learn from each other in terms of the types of studies that are being conducted, the type of policy, and the type of programs. I will add, we have 4 countries from South Asia represented. Of course, the region is much larger, but just for obvious reasons of logistics, we hope that this can be an ongoing set of conversations across different countries in South Asia. So today we're just starting with 4 of us right now. So we have a super panel that we put together that I'm very excited to introduce you all to. In terms of who we have here today, we'll be putting the full bios in the chat, but just to introduce you to who we have here today, we have Kausar Afsana, who is joining us from Bangladesh, who has been a long time expert in women's health and maternal health issues in Bangladesh, first at BRAC, the NGO, and then at the BRAC School of Public Health in Bangladesh. And she has worked across probably all of the issues that affect women's health through the life course. And thank you for joining us, Kausar. We have Dipti Goval, also my colleague on the study I mentioned, who's joining us from the International Institute for Population Sciences in Mumbai, in India. And Dipti works on issues related to aging, women's health through the life course, gynecologic health, menopause, and sort of, again, the life course. The third person we have joining us from Pakistan, from Karachi, is Neha Munkani, who works with 2 institutions. She's a midwife, practicing midwife. She works with the International Confederation of Midwives, as well as an organization she started called the Mama Baby Fund, where she's worked, again, in both providing services. So she has extensive experience in service delivery, as well as the larger contextual issues that affect access to sexual and reproductive health services in Pakistan. And then we have Ramya Kumar, who's joining us from Sri Lanka. Ramya is, in addition to being a professor in the Department of Community and Family Medicine in Jaffna, she works around healthcare, gender and health, issues around the politics of global health. And she also is an associate editor of Sexual and Reproductive Health Matters. So we're very excited to have you here from those both angles, Ramya. And my colleague Nemat Chadda is here from the George Institute. Nemat has been a research fellow at the George, working on issues related to equity, community participation, and primary health care. And her PhD work has actually focused on early hysterectomy in India, and she's also part of the study that I mentioned. So we are going to have a fairly informal conversation, because we want this to be a chance for everyone to discuss what issues are facing everyone across different countries in the region. But then also we've ensured we've kept half an hour for questions and answers from you, our participants, of whom I see we now have a lot. So thank you all for joining from different places. So we will have the chat function open. So please, at any time, feel free to just put questions into the chat or comments that you'd like to make, and introduce yourself as well, so we know where you're coming from. And then we'll go through a session where we can have people answer those. So at that, I think I'm going to start our discussion. So I'm going to first start by asking everyone to do a bit of context setting in terms of what the big issues are in women's health in the country which you work, and also within those big issues in women's health, if at all, does gynecologic health fit in as a priority? And I will start with Gausa, please.
Hello, everyone, and good morning and good evening to whoever is attending from different parts of the world. And thank you, Ne, for organizing this event. I'm so delighted that I'm able to come here. And today I would like to speak about Bangladesh, because that's where I live and I know more than any other countries. So Bangladesh, we have a 180 million population and half of them are women. So we always focus, and we all grow with reproductive age. We're very different. We varied experiences we have in our women's health issues. But whenever when you speak about women's health, that is so broad. So we try to focus today on gynecological health, because this is a really, really new, not new, but in terms of our discussion, is very new in the countries. So if you say ask me that what's the gynecological health in terms of your definition, or how do you define it? Firstly, I would like to say that, we all start at some point of our life, that menstruation. And in the menstruation, it's not only the menstruation, the menstrual health, but it's beyond that. What are the, experiences we do have, and what kind of things we are accessing, and what kind of knowledge we do have, many other issues. And more importantly, we do have many problems that girls suffer, that especially with the pain, and you can't the workplace, the school, there are many things that what happens among the younger ones. And also with aging, there are other issues also coming in terms of the gynecological health. So this is quite critical in terms of dysmenorrhea, menorrhagia, heavy bleeding, this kind of thing, even the problems in uterus, and many other issues. We'll come back to that. But if we think about women's health, then we all think about that, in as just we heard from our speaker, that the women's health is mostly maternal health. That's what we have been doing in whole South Asia. Maybe one or two countries could be exception. And maternal health is still, we're suffering. We couldn't even achieve that what SDG is pushing us to do. And in terms of enjoying, because in terms of all the life course changes in our life, everything is biological or physiological or natural, whatever you want to say. That's how we progress through our life. But what happened that sometimes we actually make it very medicalized way of thinking, how menstruation is defined and even pregnancy is defined. So that's where I know that we also discussed about politics and other issues that is coming in. So we need to, as a public health professional or researchers or practitioner, we have to keep it in mind that these are all important issues. And then going to that hysterectomy, and as you mentioned, Sapna, that hysterectomy is also one of the things that are happening. We know that at some point in our life, as I start with menstruation, we could menopause. Then maybe we have some other problems. This is natural. But in terms of doing hysterectomy and other things, and as you do induced kind of menopause, we need to think about that, whether it is necessary or it is actually very biomedical authoritative knowledge, which is actually influence women to be encouraged to have hysterectomy, and the medical professionals to do hysterectomy. Yes, it is important. I don't want to argue on this. Maybe there are gynecologists also attending. I actually did a very small study long time back when I was young. that was about the reproductive morbidities women suffering in Bangladesh. And I have kept in mind is the fistula, because we wanted to have a program on fistula. But what happened then when we started having discussion with women, mostly everyone was talking about their uterine prolapse, they have the other problems that women are suffering, that incontinence. It's actually, in women's life is very, very negligible. People don't focus on these issues, but these are affecting women's health. And then beyond that, reproductive tract infections, which is more or less, if you go to rural area, urban area, in different parts, everyone will say that, yeah, I'm having white discharge, I'm having itching. So that is one kind of expression of reproductive tract infections. And these are all preventable. How could you do that? These are very important issues that we, as the public health professionals or researchers, we need to think. And then coming about the major killers in our country, which is increasingly on rise, is cervical cancer. And you know that in Bangladesh's government has very recently started human papilloma, the HPV vaccine, but we actually know as a public health professional, it doesn't cover the whole strain of, there are many viruses of human papilloma virus. It affects some,
Oh, sir,
but
I'm going
we
to.
have to think, yeah. So
Right.
that's what is happening in my country. And at the same time, you know that we have to do many other issues. We'll listen to others and I'll stop here. So yeah, thank you.
Thank you so much for setting the stage in Bangladesh. I'm going to move to Dipti to talk to us about the context.
Yeah, thank you, Sapna and Naimat, for making this webinar happen. And hello, everyone. So I will be primarily talking about what is actually happening in India, and it's like thank you so much, Dr. Kausa, for setting up this stage, because it's really wonderful to know that what is actually happening in Bangladesh. So. So let me start actually. So if you see women in India, generally they face different sets of health problems. And when we talk about women, generally in the women's life, reproductive capacity plays an important role in shaping their lives as well as their health experiences. So, if we look at the women's health in terms of India, it primarily embraces the aspects of reproductive and sexual health, which highlights issues related to maternal well being, which even is happening in Bangladesh, as well as we also discuss about the reproductive life plans like issues related to infertility, parenting, contraception, and family planning. As well as we go ahead and discuss little bit about the sexually transmitted infections because they are directly related to women's health as well as even the child health. Then the issues on menstruation, gynecological disorders, along with the breast health, is also being focused. Along with that, the various non-reproductive health issues like violence against women, nutrition, gynecological cancer, cardiovascular diseases, dementia, bone health, mental health, as well as you can name any kind of a UTI or tract infections, have also paved their ways in our policies and healthcare system as well as writings of the researcher. So these dimensions, whenever we talk about these dimensions of the women's health, they are primarily reviewed, evaluated, and addressed in the context of biological differences, as well as certain social, cultural, economic dimensions also come into the way as women face disadvantages based on the poverty, gender, and health inequalities, and lack of reproductive rights, along with the poor empowerment. So, in this realm of health dimensions, some are on forefront and covered by various government initiatives. However, some remain under discussions and are given least priority by the healthcare system. For example, gynecological health, including menstruation, is not only an important component of women's health during their reproductive years, but throughout the course of their lives. So, though the Indian women spent substantial year after cessation of menstruation due to surgeries of the reproductive organs or the menopause before they delve into the old age. These women, as well as healthcare system, mistakenly believe that attention on gynecological health and the health beyond reproduction is no longer necessary. And this is like a kind of a satire that we women ourselves do not realize that how important is this kind of health for us. And this is precisely the point in which in the life when these women are at the greater risk of cancers, uterine prolapse, as well as they are standing at the doorstep of several non-communicable diseases. So, the issues of common gynecological and menstrual problems like discharge, menstrual irregularities, dysmenorrhea, endometriosis, fibroids, PCODs are hardly diagnosed and sought treatment for, which increase the risk of women to suffer in the later years. So, the research in India as well as our own understanding actually reveals that women themselves neglect their health, which includes frequently underreporting of these kind of various kind of illnesses, as well as ignoring not so grave issues like gynecological and menstrual morbidities, and the effect of good nutrition on health, as well as lack of awareness on the health preventive measures, which actually ultimately creates constraint in receiving adequate health care wherever required and having a good quality of life. So this is my take on Indian context. Thank you.
Thank you, Dipti. And I'm going to move to Ramya and then to Neha. So Ramya, do you want to take us to Sri Lanka?
Thank you so much for inviting me to speak today. So I would like to frame this question more broadly, actually. So in Sri Lanka, I think free health and free education have been very critical for the advancement of women's health. And these policies have been in place for over 70 years. They have together contributed to the maternal health indicators that all of you would have heard about. They're widely cited, including like a maternal mortality ratio of around 30 deaths per 100,000 live births, and wide coverage and access to maternal health services. 99% skilled attendance at birth, 99% institutional deliveries. So, and the vast majority of these taking place in our free public health system. So therefore, I would say cuts to spending in these sectors and their privatization since the 1980s are major women's health issues, and we don't really see them as such. But when we consider women's health specifically, like elsewhere, and like the speakers already mentioned, it is framed in relation to reproductive health, and the vast majority of resources are channeled into maternal health. This is reflected in high rates of service utilization and the indicators that I just mentioned. However, even with maternal health, there are, there's so much happening in the sector that is not really discussed. For instance, rising out-of-pocket expenses that disproportionately burden the poor. I should also mention the striking rural and urban disparities in access to facilities, health workers, which we see reflected in district maternal mortality ratios that vary from about 100 in Kilinochchi in the Rani in the northern province to 12 in the Gaul district in the southern province in 2021, according to Ministry of Health data. So a second issue here is that health data are not routinely disaggregated by variables other than age, sex, and district. So we do not really know breakdowns in terms of ethnicity, although rates are higher in districts in northern Sri Lanka, plantation communities, and so on. So reports suggest that obstetric violence is experienced disproportionately by ethnic minorities as well. So what I was trying to do here is to first say, okay, so everyone thinks maternal health is really great in Sri Lanka. Okay, sure, we have that system set up, but there are all kinds of issues happening, within that sector as well. I mean, the limited, area of maternal health. So if we look at reproductive health beyond maternal health, there are huge gaps. So for instance, even single working women are not routinely, targeted for services by their area public health midwives. So Sri Lanka, I mean, each of us as a public health midwife area. So we have access to the midwife, but then they prioritize certain groups for their services. So they focus on women living in partners, with their partners or spouses. So therefore, a large proportion of sexually active women, including single women, LGBTIQ plus groups, widows, divorced, separated women, all these people who do not fall within traditional family structures are basically left out. So also sexual health is not openly discussed. For instance, in the school health education curriculum, this issue is skirted, does not provide information on contraception, placing younger women and others at risk of pregnancy and contracting STIs. So in fact, HIV rates are mounting as we speak. Sri Lanka has one of the most stringent abortion laws in South Asia, and the rates of abortion due to unmet need are thought to be very high. Another neglected area in reproductive health is subfertility, which is rising at alarming rates of polycystic ovarian syndrome, and with that there are the limited access to subfertility services through the public system, causing inequities in access. Also, we have sexual and gender-based violence. Although it has been recently integrated into the services in the preventive sector, they are not a priority. Now this is like in the traditional reproductive health, young women. So I kind of talked about the issues there. So when we move on to reproductive health of older women, although we have well women clinics which are offered through the public system, right? I will be talking about that in the next round. So they remain understaffed and under-resourced, right? They are not also a state priority, and uptake of these of cervical cancer screening services are quite low. Perimenopausal health and the menopause remain largely neglected, as issues like urinary incontinence and things like that, which are really not discussed. I'll talk about that more later. And although breast cancer is rising, we don't have freely accessible mammography for all in the public system. Lastly, I'd like to talk a little bit about NCD prevention and control efforts. So they emphasize screening for early detection, but not prevention through targeted public policy. So although we have strong anti-tobacco legislation, rates of smoking among women are rising. They are targeted by both the tobacco and alcohol industries. And efforts to regulate the food industry are limited. Overweight and obesity are disproportionately, experienced by women. And just before I end, I want to highlight mental health issues, and related to that, a major concern is that the care burden for all these services that are missing in our system, the care burden is, shouldered by women. And this is also a major women's health issue. So I will stop there and go in the next round. Thank you.
Thanks very much, Ramya, for also broadening the scope of how we're thinking, because as I think I mentioned at the beginning, but we all are very aware that all of these issues are connected across the life course. So it's not that women's health can be reduced only to gynecologic health, or that we can look at women's health without looking at those issues as well. And lastly, I'm going to turn to Neha.
Thank you, Sapna, and thank you for this really important webinar. And I think it's really been interesting for me to see since I've learned about this webinar, but also today when I hear all of other speakers, how the issues that we're seeing across South Asia are just so similar. So I would say that, all of the issues that have already been highlighted in terms of women's health, the kind of things that women are experiencing by Kausar, by Deepti, by Ramya, are also applicable in Pakistan. And of course, so I'll talk a little bit about the backdrop. So again, Pakistan is obviously very overpopulated. It's 240 million, much like India, somewhere in between India and Bangladesh. So it's crucial to acknowledge, obviously, the sheer scale of the issue of women's health challenges. So we have a growing population, which obviously places immense pressure on our healthcare system. And the demand for women's health services really outstrips the available resources, particularly within the public sector, which is the only free form of healthcare that we have. So we have a midwifery population, but even that, we have a big population of midwives who provide obstetric care, but even that is a cadre that needs a lot of work. So there is also a lot of quality issues in healthcare providers. And so women often will rely on private healthcare where costs are high and regulation can be very inconsistent. So there's mushrooming of small private clinics all over which are unregulated and they provide often very low quality care. But if often it's all that people have, there's a small clinic in your lane, so that's where you go. So this means that, all reproductive health services are actually quite difficult to access, including birthing services. But those, obviously, those that are considered less important, like gynecological health, are much less understood, so they're more difficult to access. So this brings us to an important point, the deeply ingrained social cultural norms that influence women's health. So I see a lot, so I've worked in various hospitals, worked with a lot of different healthcare providers, and Pakistan is a very medicalized society. Even though we have poor health outcomes, we're very medicalized. So we see a very paternalistic approach from healthcare providers. So when I say this, I mean this dynamic in which the doctor assumes the role or the midwife will assume the role of the decision maker, often overlooking the patient's preferences. So we see really alarming high rates of medical interventions, which includes lots of C-sections, really high C-section rates, lots of hysterectomies performed at very young ages. And this is often driven by a combination of factors, which includes like limited understanding of alternative treatments for common issues like fibroids, menorrhagia, and also this whole thing of this idea that we have of the uterus as unnecessary after childbirth. And then the third thing is just this lack of informed decision making, where you don't have the information that you need to be able to make an informed decision. So as a result of this, there's obviously limited patient input. The doctors often will present medical options for gynecological issues as the only viable solution without explaining potential risk benefits. So women are often pressured to make decisions around their health. There's obviously, again, dismissal of concerns and not really highlighting what can happen. Like if you have a radical hysterectomy and you enter early menopause, like in your early 30s, what does that mean for the rest of your life? And focus on convenience, which we see in C-sections as well, where doctors will emphasize, midwives will emphasize the ease and convenience of an intervention, which kind of so that if you get this intervention, it eliminate menstrual problems, and you won't even have future pregnancies, which doesn't again look at consequences. And this again obviously is linked to limited training, to time constraints in the really busy healthcare system, and societal perceptions. And the other thing, the reason why I think a lot of this happens is because there's this gap in prioritization is also reflected in funding. So we have, the government has prioritized maternal health, which is great to see. They're really trying to do emergency obstetric care, work on maternal health, work on family planning. But gynecological issues beyond reproduction are neglected because linked to the funding gaps too. Which means, again, providers don't have evidence-based information. And then the last thing is there's this pervasive, which I think others have mentioned as well, which is this pervasive stigma and shame surrounding gynae issues. So while childbirth is openly discussed, everyone can talk about it. Other aspects of women's health remain quite shrouded in silence. Like people are not talking about it, which means often people don't seek care. So I've worked in hospitals where women will come in with like advanced gynecological cancer, or they're very anemic because they've just been bleeding for years, but they can't say anything because they just don't have the word language and don't feel like they can speak about their body in with their families. And then the last thing is this idea of communal ownership of women's bodies, where decision making around everything related to women's health and women's bodies is done by, it's not really a woman's decision always alone. A lot of times it's families, communities, mother-in-law, husband, all come together to kind of make a decision and also to do resource allocation. So which means, again, that things that are not considered very high priority is swept under the rug. So this is a little bit about what the situation in Pakistan is like. Thank you.
Thank you, Neha, for bringing us also to those underlying determinants, as well as reminding us that, so much of this is linked to prioritization and funding, which is, again, I think, amplifies the need for conversations like these to talk about what advocacy priorities should be and funding priorities should be as some of these issues come to the fore. I mean, we certainly came to this from another route in India when we saw rates of hysterectomy, but even that was linked to a long history of advocacy and sort of evidence gathering. So I'm going to now switch gears for a minute and ask everyone to think about or tell us about what are the main things your countries are doing in each of your settings in terms of addressing gynecologic health to the extent they are, and you focus on different aspects of that, of course. And I'm going to start with Dipti.
Yeah, thank you, Sapna. So, we have a very strong focus on women's health, and this strong focus is coming from the National Rural Health Missions and now converted to the National Health Mission and Janani Suraksha Yojana and many other programs which are running parallelly to the betterment of the women's health, or you can say the maternal health primarily. But when we talk about a women's need for the healthcare beyond childbearing ages, which are poorly addressed by these particular programs. So especially when we talk about RTIs, menstrual health concerns, they remain unreported as well as undiagnosed during reproduction, which I mentioned in the previous when I was talking about the India's health concerns. So an interesting part is that as soon as the status of the women change from reproduction to the non-reproduction, either by cessation of menstruation or even after sterilization, their health needs move out of the purview of healthcare delivery system. And there is very limited outreach activities, if there are some area specific, which are performed to capture the health status of such kind of a women. And these kind of actions actually, because till now we have not reached to the stage where we are able to provide the services to these women. So several times we make them they feel very dejected and not even important. They don't feel that their health is beyond reproductive health. Their health is very important, and they start neglecting their health. So generally, many of those issues, when we talk about the cancers, we talk about the non-communicable diseases, these kind of different issues and the well-being of the women after reproductive years are directly captured through the old age policies and different kind of interventions which are happening in the old age. But the health of the women in these particular years are neither captured by the reproductive health policies or not captured by the old age concerns. So these two dimensions, the spectrum of the two side of the reproductive health and the old age, do not actually talk about the health of the women, those who are in the middle ages or they have completed their their reproduction responsibilities. So if we start looking at the data which our country is actually collecting. So at present, if you see the India's large scale surveys like NFHS and LASI, I hope everybody knows National Family Health Survey, and then we have a longitudinal aging study in India. They are actually collecting information of slightly little bit on menstrual status of women with the help of the questions on last menstrual period and removal of the uterus, which researchers are actually analyzing and alerting the government and the non-government organizations about the over medicalization of women's body and the effect of early cessation of menstruation on the health of the women. So even we have conducted some research and which indicates that hysterectomy and early menopause has a high association with the early onset of non-communicable diseases in the early ages. And also the age at which the women are undergoing menopause and hysterectomy in India are relatively much lower, which leaves us with many more years for the women to survive in the isolation and not being addressed by the healthcare system. On the other hand, we do lack data on the burden of gynecological and menstrual morbidities. The data which we used to collect earlier, now it has been gradually stopped, considering what I consider, it's my personal view, may be not considered as an important component to be addressed too. Okay, therefore, hence the timely interventions which pushes women, it's not there actually. Timely interventions are not there. And because of those lack of data as well as no intervention is available for the women to take care of their menstrual morbidities and gynecological morbidities, they push these women towards not so good health and health experiences and even early onset of menopause or surgical removal of the uterus. In the recent past, if you look at, India has actually witnessed the increase in the hysterectomy operations across the different parts of the country. There were multiple reasons along with the you can say the overuse of the insurance. So to monitor and reduce the unnecessary hysterectomies, the timely initiative of initiative of Ministry of Health and Family Welfare in the form of producing guidelines to monitor unnecessary hysterectomies, introduction of strict punitive measures of blacklisting and de-empaneling the healthcare facilities during doing unnecessary procedures are welcomed. But interestingly, on the other hand, India's public and private health sector do not have any particular policies regarding the post-hysterectomy and menopause management, which leaves behind a bulk of women deprived of the healthcare. So, with limited evidence on the concerned issues, evaluation of the implementation of guidelines, and restrictive focus on the health beyond reproduction in the present healthcare system, we, India, as a most populated country in the world, have a very long way to address all the health concerns of all Indian women. So we need to actually broaden our focus on the women's health and need to actually recognize, or you can say the adopt the life cycle approach while advocating the women's health agenda instead of looking the life of the women in isolation. Thank you so much.
Thank you, Dipti. And I want to amplify one thing in terms of the data you mentioned is that there was actually, in addition to the demographic and health surveys, so the NFHS, which you all have the DHS in each country, the ministry added 4 questions to collect data on hysterectomy. So interestingly, it's the only country in the world right now on the DHS that collects this. And it's also something to consider in other contexts as these problems emerge. So I just wanted to amplify that. And thank you so much, Dipti, in giving the sort of Lifecourse perspective again, even on the evidence. I'm going to come back to you in a minute, Dipti. After, I'm going to turn to Ramya, and then I'll give you another round. Ramya.
Okay, so if we talk about the range of, just a minute, I've done myself. So the range of women's health services in Sri Lanka, just let me first describe the health system more broadly. If you take service delivery, about 90% of inpatient admissions and 40 to 50% of outpatient visits, and the bulk of preventive health care still takes place in the public sector. Over the decades, funding for public health has steadily decreased, with more and more channeled into hospital-based curative care. So when we consider women's health services, then we can also think of them as public and private. I would like to focus on the public, which is what most people access. But before that, very briefly, in the private sector, services are delivered on a fee-for-service basis. So when confronted with a health problem, you might see a GP if you have one, or there are some who go to general practitioners, but mostly they might directly consult a specialist, right? And both these categories are mostly dual practitioners, so it's quite easy to consult them for on an outpatient basis and then get back into the system. So it is a very small minority that access only the private sector, and that's mostly the urban elite. So the vast majority tend to combine public with private, maybe a little bit of private or more private based on their ability to pay. So in the public system, it is the preventive health system that is well organized. So the whole country is divided into 350 plus health areas, which are called medical officer of health areas. And one of these are about 50 to 60,000 population. These are further divided into public health midwife areas for about 3 to 5,000 population. So the public health midwife in each, what she would do is she registers so-called eligible families for services. So these families are women of reproductive age living in union. So all pregnant women, and as well as families with children less than 5 years. So you can see the focus is on maternal and child health. So the PHM then conducts home visits and also invites these women to attend polyclinics which are held in the area. So in addition, the public health midwife invites all women of age 35 and 45 years. So the age cohort each year to the Well Women clinics. So that would mean next year it would be the women who are 34 and 44 this year. These clinics are held on specified days and they offer cervical cancer screening, clinical breast examination, measurement of body weight, blood sugar, blood pressure, family planning services, referral for menstrual problems, and so on. So this is actually part of the Ministry of Health's NCD control strategy as well as reproductive health. So while women who are 35 and 45 are invited and actively recruited, any woman above 35 years of age may access these services. However, these well-woman clinics are understaffed and resourced. They are not used like maternal and childhood services, where it's very high, the proportion going using those community-based services. So women are reluctant to have pap smears due to poor understanding of its purpose and also the poor infrastructure, lack of privacy, unavailability of women providers, and so on. Many medical officer of health areas do not have a public health nursing system owing to staff shortages. So that's the category that's trained to provide the service apart from doctors. So the midwives don't actually do pap smears. The clinics are held at inconvenient hours for working women and so on. Pap smear uptake is quite low at around 40% with wide district-based variations where in some districts it's less than 20%. So, but generally what actually happens is that once a woman is faced with a gynecological issue, they wouldn't, most don't go to those clinics. What they would do is they would go directly to the outpatient department of a public hospital and get their problems sorted out. So, you know, including perimenopausal bleeding and things like that. And but some women may visit, you know, go to the private sector directly and see a GP, or if they can afford it, a gynecologist. And as I mentioned earlier, because they are dual practitioners, the gynecologist might refer the patient back to the public hospital that they work in, especially if surgical management is required. If the woman can afford it, of course, they would continue treatment in the private sector, but most do not do this. Now, when you consider treatment of menopause and perimenopausal problems, that it's highly medicalized. Mostly, the treatment is offered through the private sector, and things like, you know, how to manage these problems through a lifestyle modification and those kinds of things are not really prioritized. However, what I would say is, compared to, you know, what we've been hearing in this seminar, I guess what is important is that the infrastructure and system exists for women to access community-based services close to their homes and be referred, if necessary, to secondary and tertiary care centers to address their gynecological health. However, more investment is needed in this system. So I will stop there and answer any questions later. Thanks.
Thank you so much, Ramya. And it sounds like it's very important for regional learning in terms of the structure and how these clinics work in different contexts. So thank you for that. I am going to turn to Neha now.
Thank you, Sapna. So I'm going to talk a little bit. Actually, some of the work that I do is similar to the work that Ramya is mentioning, and it's interesting that midwives. You mentioned midwives because this is, as a midwife, I feel like some of the things that I saw which led me to do this work is what I wanted to share. So I do, as a midwife, you know, the way that we've been trained, I do try to have a very holistic approach to women's health. But a little bit about my work. So I provide care at an island community, and the clinic, basically what we did was that through the organization, my Mama Baby Fund, we set up a free pregnancy and well baby clinic. And we have referrals to the city because this is an island community and we serve a population of 40,000. So, and it was the only free women's health clinic and actually any women's health clinic in the area. But once I had set it up, it was a pregnancy clinic, but I realized that I need to take a broader approach towards gynecological health and women's wellness because just the kind of things that I was seeing. And I think it's important to realize how a life cycle approach to these things really changes women's health outcomes throughout their lives beyond birth. So first, I'd like to make that connection between obstetric care and gynecological health. And one of the things that Costa mentioned, fistula as well, is that physical trauma in bad obstetric care is a really big thing. So when I first started this clinic, and also in many other spaces that I've worked in, I've seen that complications during childbirth, such as prolonged labor, instrumental deliveries, poorly managed tears, they can all lead to pelvic floor damage, which later then manifests as fistulas or urinary incontinence, pelvic organ prolapse, sexual dysfunction, chronic pelvic pain. So then there is infections. A lot of people who end up giving birth in small clinics, or they give birth in unsafe and unsanitary situations, which don't have proper infection control, it really increases the risk of postpartum infections, which are often left untreated and poorly managed. And I see a lot of women who have long-term damage to reproductive organs, leading to chronic pelvic inflammatory disease, chronic pain, who have, they might have had one miscarriage at a small clinic somewhere where someone did a pelvic exam without gloves or something like that, and it just affects them their entire life. Then there is uterine damage. So this might be something that I think other countries see too, which is that, as I mentioned, we have a very high C-section rate. And so procedures like C-sections, which obviously sometimes are necessary, but also many times are not, can carry risks of complications such as adhesions and scar tissue formation. So in Pakistan, where we have a high rate, by the time many women get to their third or fourth C-section, which is often in their early 30s, mid 30s, we have a very high rate of placenta accreta, which means by the time you have this fourth C-section, third C-section, the placenta adheres abnormally to the uterine wall. And so when the woman has a baby, she has C-section, often her uterus will need to be removed as well. And often there'll also be bladder involvement. So there's a lot of damage. And I think even when that surgery happens, no one actually speaks to women about what's going to happen next. Then there's hormonal imbalances, where women have had postpartum hemorrhage, or they've had a retained placenta, which often leads to disrupts their hormonal balances and can lead to irregular menstruation, infertility, and other gynecological problems. And then psychological trauma, which I think is a really big part of it, which is a traumatic birth experience, or if you don't have postpartum care, which can lead to mental health issues like anxiety and depression. And a really big part of this is like disrespect and abuse, which I think all of us have seen in our countries, disrespect and abuse in the childbirth process. And this can often lead to really ruin a woman's overall well-being, including her sexual health. So, and then there's obviously neglect of underlying conditions, where a lot of times, for example, if you have gestational diabetes, if poorly managed, increases the risk of type 2 diabetes later in life. So a lot of these underlying issues, which left untreated, can have gynecological implications as well. So I wanted to be able to address these challenges before they happen. So that's part of the provision of safe care that we do. And while the government doesn't have a very large focus on gynae issues, they do have a big focus on maternal health. And I hope through that they can address some of the services, and through improved care, they can address some of these challenges. But the last thing I want to talk about is that through my clinic, we started funding some gynecological referrals because there were no spaces and there was no funding for holistic well-being. So we started funding some gynae work. And as soon as we started funding this gynae work, a lot of women, sometimes as young as early 30s, came in asking for hysterectomies because they were really tired of being anemic and excessive bleeding, being uncomfortable, having chronic pain, and receiving this messaging that this is the only solution. So in this clinic, I have really tried to change how we speak about women's health and women's bodies, and realize that, when you have a safe space to discuss things like sexual health and pleasure and dyspareunia and menorrhagia and relationships with your body and menopause and how your life and body changes over the years, it really changes your relationship with the process as well. So when women now come in asking about hysterectomies, I think it's the first time that someone is opening a conversation with them about what early hysterectomies and radical hysterectomies and early menopause can do to their health and lives going forward. And because it's a small community, I am starting to see this permeability in the messages, and it kind of changes how women and families view this topic. So this has actually been a really interesting process, but again, I am very cognizant of the fact that as a midwife, I am limited in terms of service provision. So I have limitations, and I do in the end refer women out to services, and often they'll go back to clinics and facilities where the messaging they receive is very different. So until there's a complete systemic overhaul, I think what I can do is limited, but These are just some of the things that we've been trying. Thank you.
Thank you so much, Neha, and also for the inspirational model in terms of how the actual conversation framing needs to change at its root. I am going to turn to Kausar now to wrap us up on this section. So over to you.
Thank you. It's overwhelming. Thank you so much. I think I am enlightened listening to all those interventions happening, in different parts of the world. And for myself, still, I feel that, women's health, and as we have divided into maternal health in one part, and also we haven't talked much about family planning, which is a major issue is playing in women's health. And lastly, I think I should come to gynecological health, which is critical because in my country, in policy discussion, there is no way that we have been discussing about gynecological health, not even hysterectomy, sorry about this. And we have passed 30 years, right, after ICPD and Beijing Platform of Action. And after that, many discussion has been going on. But unfortunately, at the country level, we don't have enough data to understand that what is the magnitude of the problem and how we are going to address. Even it is, as I said, magnitude. Magnitude doesn't mean that, we have everyone will be suffering. But we know that in Bangladesh, one of the things happening at this moment is the C-section rate is skyrocket increasing like you can't even imagine. I think almost 80% of the women who are going to the public health facilities, they're having C-section. So, and in public hospitals, it is the situation. I said private hospitals, sorry, it's the private hospitals. But in terms of hysterectomy and other issues that we have been discussing, we have small example, the way it's explained in terms of, how the NGOs are working in different parts of Bangladesh, that how they develop their own referral system. But at the end of the day, we need to have a public health system to incorporate this. Otherwise, a certain segment of the people will be getting the services and most are not going to get the services. So one of the example Bangladesh has been doing not successfully, but recently, a few years back started, is the test for cervical cancer. But also is visual inspection with acetic acid, which is called VR test, and it's mandatory for all women. But unfortunately, because of our lack of awareness and not having enough campaign that it should be done, that is not happening. That means a very simple test maybe has given you give you a little bit of shade at what we can do, and that is also not being we are not being influenced or encouraged to do so. And it's important. That kind of campaign is missing, advocacy is missing, and we need to have more data to talk about this, or even for anecdotes to talk about this. And this responsibility actually falls on us, that who are working in the creation of evidence and we doing some kind of policy advocacy, even writing on this. And that is not enough to draw the attention of our policymakers at the country level. So as I see that in India, you have been successfully done one thing, that DHS is collecting data on hysterectomy. That's phenomenal. I think I must congratulate you. And it is not there in Bangladesh and even in other countries. So that means that evidence generation, doing rightly, that how we'll be doing our advocacy and also pushing a different forum. This is one of the forum that we are trying to raise our voice for women's health. And in terms of, as I'm also a lot much involved in the primary health care, universal health coverage, and even for self-care for SRHR. So I can see that, there is actually some space to work in self-care if we can, in terms of our own personal hygiene, or for menstrual hygiene. We know that we can promote self-care, but unfortunately, in terms of defining self-care interventions in every country in South Asia, it's not there. So that time has come. You can start with the simple thing and you can move. And then you can connect with the primary healthcare, which is the setting. Wherever we are turning our women with gynecological health problems, all ending up in secondary healthcare or tertiary healthcare or private health. hospitals. So there's a huge healthcare expenditure. So we are working to achieve our universal health coverage. And one of the SDGs 3.7, I think we are focusing on universal access to sexual and reproductive health care and beyond that. So that means that, we are completely, either we are not focusing ourselves to this specific issues because we are still working on maternal health, struggling with maternal health and family planning, and but not focusing that women as a holistic person, that they need help from many different aspects. And I really like that the mental health issues, which is actually, everyone we are passing our life, and mental health is an important component. And physical and mental health, we know that we cannot separate mind and body. If you really would like to work, mind and body together, we have to have our mental health component in our all health problems. I mean, even we have hysterectomy. Mental health is a huge issue for women. If suddenly they know that they have to go for hysterectomy, and this kind of issues are so critical, we cannot separate it out. So I feel that how could you integrate it? That's also our responsibility. We cannot just say policymakers to invest in this, because we don't have enough evidence to create that kind of knowledge and awareness to invest and to do interventions. And in all the countries I was looking at it, I think Bangladesh is one of our, or Nepal maybe, two countries actually investing less than 1% GDP in healthcare. India probably costs 2%, maybe 3, not more than that. So that is our situation. Think about that. If it is the investment in healthcare, so how we are expecting that we will be doing the great work that we have been thinking. But as you have started thinking, that's our responsibility to push and do more in this area. In terms of, from my perspective, as I'm a research, push for evidence generation, and and also you're doing policy advocacy. We need to push ourselves to do more policy advocacy in this area, to invest and to do better designing and better interventions that each woman could access healthcare.
Thank you so much, Kausar, and raising that very important point around policy advocacy, which is, again, this is one small effort to sort of, I think, catalyze a lot more at our local levels. Before we turn to the question and answers, because questions, I see a few in the chat already. I want to ask if any of the panelists want to clarify anything or add anything that came to you. I know, Dipti, I'll just give you all a minute if you want to add anything. Dipti, you had a clarification I think you wanted to make, and then I'll open it up to the rest of you for a minute before turning over to Nemat.
No, I just wanted to add that now the countries are coming forward to add this question on hysterectomy in their own DHS. So it's a welcoming move. Yeah.
Thank you. Anyone else?
I would like to say that there's really no data on these kinds of conditions in women's health. It's just in Sri Lanka, it's mostly, limited to conditions experienced by women during pregnancy, the data that we have.
I would like to raise one issue on the issue of intersectionality that Ramaya actually addressed in her when she was talking about maternal health. And this is another thing that I know that we don't have enough data, but we have to keep it in mind that we must have data from different segmented populations across the country. Even especially in my country, we do have small populations who are minorities, like ethnic minorities, and but they do not have access always to healthcare. They may not have, simple access to maternal health care. So basic things are not there. So, but data is not always you can find. So having data, even for DHS to have, disaggregated data on this is really important to understand more about all the issues that we have been talking about.
Thank you, Kausar and Neha. I think you were about to add
Yes.
something.
So I just want, so I would second everyone's everyone's thoughts about data specifically, because we, again, don't have any evidence about gynecological, very little work being done that we can, and if you don't have evidence, like a lot of the work that we do is around knowledge equity and how it's really important for you to do any kind of evidence-based care. But also, I think what I feel like surprises a lot of people is the connection now that we're seeing between things like hysterectomies and even like maternal health and reproductive health of women and gynecological health of women and climate change and things like what's happening because of heat and environmental degradation and reduced produce and some of the work that Nehmet's been doing as well. We're seeing these things. And I think just getting all of that information out there is also so important, because I mean, in my work, I do a lot of work around climate and maternal health. And anytime I mention these kind of connections to people, I feel like there's a lot of surprise. And I just feel like these things, just this kind of content, there is a lot more need to generate evidence and just disseminate widely so that people know what they're up against.
Thank you, everyone. I'm going to turn over to Nemat now to the questions. But thank you all so much for that, for sharing. And I think we're going to hear a lot more from the questions, but it's been really, really enriching. So over to you, Nemat.
Thanks, Sapna. Thanks, everybody. So I've picked up a few questions that we've received on the chat, and I think most of the questions are pretty much open-ended for all of the panelists, so feel free to jump in. So the first question that we have is from Devki, who is from the George Institute and is also a member of Saheli. So Devki's question is that she's wondering if the panelists could talk through the examples of where data was brought to bear to either expand service access or the data ecosystem in your own country contexts. So for example, what Sapna was talking about, the inclusion of hysterectomy questions in DHS. So if there's something from your own country context in terms of data that you would just like to, shed a little bit light on, that would be very interesting. So over to any of you who wants to take this question.
Thank you, Devaki, for your question. I saw your question, but I'm just struggling that how we should respond to your question. And yes, unfortunately, I shouldn't say in Bangladesh. I know that in DHS, especially, they collect a lot of data. But unfortunately, what happened when the report, we can see that it's not everything they publish in the DHS report. So I wish that we need to actually explore more on this. One is analyze the data, and secondly, to understand more, because recently we are working using DHS data to understand women's empowerment and food security, but through using the healthcare pathways. So especially under 5 children, and looking at these pathways, that how women's empowerment actually seeking the child care for their children, but suffering from either because two data are being collected, acute respiratory tract infections and diarrheal disease. And that was the pathway, and trying to understand how this women's empowerment impacting seeking healthcare. That's it. And it's quite interesting that, you can understand from this analysis that actually women's empowerment we know that women's empowerment to go, but we need evidence. That kind of analysis has been possible using the data, but we need also PhD students to analyze this kind of data. And but for your question, I think we don't have this data in Bangladesh at this moment. I see that small studies done in few people they do, but it's not around doing policy advocacy. It's seemingly that they get small fund, they do research, but that's it, and publish. And that's publications may not draw the attention of the policymakers at the country level. So I always feel that science policy interface that we talk a lot about nowadays, that how the scientists should be sitting with the policymakers or program people to do the research, not like I have some idea and do the research. That doesn't help the country, because it's a long process to implement and bring in strategy and policy. And you know more than me, I think, in this area you have been working. Thank you.
Thanks so much for that, Dr. Afsana. Ramya, Neha, Deepti, do you want to add something?
Sure. So in terms of data, like if you take a health information system. So there are like really huge gaps in the data. First of all, they're all like fragmented information systems. So there's nothing that kind of gives an overall picture. So in order to get that, so we have to rely on some of these surveys like the DHS and the WHO, like the STEPS survey on NCDs. And unfortunately, what I see is that all these institutions collect or do these surveys, but they don't bring all this information together and use it in a useful way. For instance, like I've noticed in the DHS, if you look at our family planning service, the data, it's very clear that long-acting contraceptives, hormonal contraceptives are used mainly by rural and estate, in the rural and estate sector, which for me raises some serious questions. But there's really that data is not considered by the Ministry of Health in designing its interventions. And we don't see, as Kausar pointed out, like there's no critical analysis of all this data, and I don't see any PhDs or students working with these data. Thanks.
Thank you so much. That's a very important point that you've made. Neha, do you have anything else to add? Neha, Deepthi, nothing?
Yeah, actually, it's a very. I have been in this field for last approximately 20 years, and we have been studying how the evidence really important is for policy making and implementation. And I'm really happy to see that how Indian government is progressing, that we have enough data on the concerned issues right now, whatever is there on the policy agenda, and we are using those data as an evidence and implementing many of those policies and programs in line with the data and evaluating those policies and programs. Apart from that, when we talk about the concerns related to the issues of non-reproduction, maybe hysterectomy and menopause, though I do not see much progress because the data which we are collecting is of very limited nature, and it just only tells you what is the prevalence of hysterectomy or maybe the menopausal age you can maximum calculate, and which clearly indicates that our Indian women actually have the early menopause or hysterectomy, and they suffer in isolation. And till now, there is a limited step which has been taken by the government, except that there are certain movements by the advocacy groups which are actually trying to sensitize the governments on the basis of a small research or a small scale research, as well as the data which we are getting from DHS surveys, to sensitize them that these are the concerns which we need to really highlight into. So hopefully in coming future, we will be able to generate some data, and we will be able to provide some policy inputs to strengthen our policies in this particular direction. Thank you, Namit.
Thanks so much, Dipti. Then I think I'll just go to the next question that we have from JK, who is working at IIPH and is also a member of the Saheli Consortium. And JK's question is that we note how medicalization of normal physiological processes is problematic, but has medicalization brought about any benefits? For example, raising the profile of some conditions, making sick leave possible, facilitating healthcare, among others. So again, this question is open for everybody, if anybody wants to jump in on this. Dr. Roxana?
Yes. Thank you. I think this is very important, but medicalization is actually that how we are exercising our authority of biomedical authority on a person. And for our case, as we have been discussing about women's health, so think about that how we are exercising on women's health. Yes, I think the maternity benefits, maternal health voucher in Bangladesh, and many, even maternity leave, paternity leave in our country. It's very successful how the evidence actually creating some kind of influences on the different ministries. And we can see that how health and the Ministry of social protection and Ministry of Social Welfare are working together in this space. This is important. But on the other hand, I would like to come back to menopause, because this is important, that this is a natural phenomena in our life. And we sometimes forget that in our in Indian subcontinent, that how traditional medicine is was playing critical role, and even now playing critical role. And these things we need to bring to focus on, because traditional medicine has historically, it's providing a lot of emphasis on how to improve your own health, how to take care of your own health. And yoga is one of the issue, and we have a lot of examples from our traditional medicine. In fact, in terms of not to medicalize to take care of our own body or our own health. This is important. And I wish that as we talk a lot about this, but how much we actually discuss, or how much data we do have, that how traditional medicine is also supporting or creating barriers. We may have some problems also with the traditional medicine, but how we can do that, because in Sri Lanka, I have seen that, and in India, in many parts of India, maybe not all, and Bhutan, they have been using traditional medicine quite immensely in their everyday health care. So this is important. But in terms of women's health, in rural areas, I saw, when I was doing my own interventions, I saw that many are going to the Kobiraj, and we don't know who are those Kobiraj. Are they trained, or, just become a quack who is giving different kind of medication? So we need to explore this area, and self-care in terms of improving our own health is possible through using traditional medicine. Menopause, I think biomedicalizing menopause is a problem to me. I wish that I could do on research, but unfortunately I couldn't do. But it's important area to understand more. One, I can say that from my own perspective, when I started my menopausing, then I try to have my attention that I will not be biomedicalized. I have to be healthy, and I don't want to have any symptoms that actually, which is I read in my medical books. So unfortunately, or unfortunately, whatever, I have not felt any symptoms that is written in the books. And I was trying to understand, especially Margaret Mead's an anthropologist, from very famous anthropologist. She did a study in Japan way back in I don't know, 80s or some time. And in Japanese tradition, actually, the women were laughing when they knew that, HRT is one of the treatment that is given for menopausal women or perimenopausal women. So this kind of thing, as a person, as a human being, as a woman, from our own culture, from our own tradition, we have to understand more about that traditional medicine, and how can you have a better life in terms of, think about the healthcare expenditure. How much you want to spend in this? We don't want to. We can do more on, primary healthcare, not to have focusing more on, other things that would actually our healthcare expenditure, especially out-of-pocket expenditure, goes up as you add more medical treatment. So that, keeping that in mind, I hope that menopause would be treated very natural physiological phenomena, and if you have problem, then you have to start preventing that from much earlier. So for that, we need to have education, awareness, and even for policy making or designing interventions for women. These are all important. And engaging community, we have not talked about this. Engaging community is very important. And that is missed out from our healthcare system day by day. We're missing them. So that's important. Thank you.
Thank you so much for that, Dr. Rosanna.
Yeah.
Neha?
Working within a very medicalized system, I feel like I would be I think it's difficult to find like a medium, like kind of ground on this, because I mean, the community I work in, I'm constantly telling them this message about that. Dr. Sana's message mentioned as well that, everything does not need to be medicalized. Like, you have a cold, you have, some mild pain somewhere, your bones are, there's so much that you can do with just, remedies, home remedies, or like just improving your lifestyle. But then at the same time, when you work in communities where women often are just doing so many different things and don't get any kind of break to do anything, like to take care of themselves, like self care is such a luxurious concept, and they don't have that. So I think it's also important. I feel like I've kind of medicalized their very normal processes sometimes, physiological processes sometimes, just so that they can get a break. And, women who, like, pregnancy, I always tell them is not an illness. But sometimes if in the postnatal process, you just need to want to spend time with the baby, you can say that, the doctor said that you need 6 weeks off from life. So I think sometimes it is important to use that system, and just so that women have the ability to take a little bit of time for themselves, because otherwise a lot of the things that they experience are just overlooked generally also. And if we overlook it, I think it just becomes worse for them.
Thanks for that, Neha. Ramya, anything you would like to add to this?
Sure. I was just thinking that, that I think there's a difference between medicalization and access to medical care. So I would say medicalization promotes a certain kind of intervention, like, excessive investigations or unnecessary surgical interventions. Often these interventions are like very technology based and kind of divorced from social context or the way people's lives. So then as a result the outcomes are not necessarily positive. So I would say that there are other ways of drawing attention to medical issues. Yeah, I mean, medicalization in that sense may bring attention, but I would say that interventions, organizing that has sort of been against medicalization. So sort of initiatives like Our Bodies Ourselves from the 1970s and feminist organizing on these issues can draw, I think, more attention to the kinds of care that we would want for women. Yeah, thank you.
Thanks, Ramya. Thanks so much. Dipti?
Yeah, actually, when somebody talks about medicalization, I always think that it's always negative. So it's like what Ramya has told. It's always negative. It comes to my mind that medicalization, over medication, operations being conducted on women, like for C-section and then hysterectomy operation, is like very negative. Though, so the concerns which we are talking about, okay, medicalization can help women to overcome the stress which she is undergoing in the day-to-day life, or getting sick leave and all those things, is actually it rules out in the rural phenomena. So the women in the rural area, they hardly get, whether you do any over medicalization or you, conduct any kind of a surgeries, even the C-sections and all, after a few days itself they have to return back to their normal life, or even if they don't want, or their body does not allow them. So the main intervention which I feel it should change the life of the women is just not the medicalization or the treatment of the women, it's also the attitude of the family, especially the husbands and the community. Because if they are supportive, any kind of health concerns can be treated or can be managed without much of the medical interventions. So it's along, or you can say, along with the medical interventions, these things can be managed very easily. But now what the scenario which we see, that the gender dimensions which crops in, or the patriarchy which crops in, the women has to bear the burden of the all the diseases, as well as all the medication which is happening, as well as all the experiments which are happening on them. So that's all. That's my point of view on that.
Thanks so much for that, Dipti. And I think that ties perfectly to the next question that we have here from Devashish. So Devashish is actually one of my batchmates at IIT who is working on Dalit food cultures and health at the intersections of caste and gender. And his question is that a major part of my research focuses on women, especially from the Dalit caste groups, food and health. So while I'm aware of most of the issues of women's health through sociological studies, I feel the helplessness of making women, especially from the Dalit communities in general, and also women like my mother and aunts, who his mother herself, she went through hysterectomy, which had caused her both somatic and like a lot of psychological health issues. Of course, because of my own gender identity. In the absence of public awareness programs, I wish to learn how, as a male, I can help to spread awareness around such issues while keeping in center my own gender identity, as it's quite difficult to wait for some people or institutions to work on beginning awareness programs in the first place. So that's a question from Devashish, which somehow stems from what Dipti was talking about, and also what Neha had mentioned about communal ownership of women's bodies. So if there's something that anybody wants to add on this, feel free to jump in. Neha, would you like to start as a practitioner? What has your experience been with something like this?
So yeah, I think the context that Devashish is speaking from is also very specific, but like I just feel that I would just like to say that, thank you for even wanting to do this work. It's really great that you're working at the intersection of caste and gender and having seen your family's experiences, you want to take that forward. And I would just say that, you don't even need to, I agree, you don't need to do anything you don't have to wait for like large institutional level change to happen to people. There's so much that you can do at the community level. And especially if you're doing research, I think that itself is such a big, it's such a big thing to do because that evidence is going to obviously spread a lot of information around. But also whatever you can do, as I think as a male, there is just so much that you can do in your own community. Like I work with men in the community that I work in, and I think that if I even find like one or two men who think like this, who take the experiences that the women in their families have been through and want to speak to other men about it, which that I think is the most important thing. That when we share these experiences, they need to be shared with the right people. They need to be shared with men. They need to be shared with decision makers in communities versus other women who already know all of these things. So yeah, I would say, you can start small, and in your community, there are people who are making these decisions around women's bodies. They're the ones that need to learn more about that. My thought. Thank you.
Thanks so much, Neha. Anybody else who wants to weigh in on this?
Actually, I'm really happy that Devashi is just thinking in this particular line. I'm really, really grateful because what Neha has actually said, that is absolutely true. If a man is speaking with men, will create more impact than women is speaking with men and the practitioner is speaking with men and educating them. So it's really wonderful that you have started thinking about it. So if you are aware, you can make many more people aware about the condition of the women or during this period of time or this phase of time. Because I feel that till now we are unable to completely make men aware through the policies and programs on even maternal and child health issues. So these issues are very, very far still we have to look for. So it will be a good what do you say, the chain of communication if we can educate our own men, and then these people can spread the word around, and it will be really helpful and for the women to actually go through or sail through the phase of this life very smoothly. Thank you so much.
Thanks, Dipti. Ramya, Dr. Afsana, anything else that you want to add?
Main support group is so important. Sorry, may I go ahead?
No, I said no. I'm okay, thanks. Sorry.
I'm just agree with everyone that men's support group or men's network is really important. And in family planning program in Bangladesh, the role of men and religious leader is very critical in terms of influencing. When Bangladesh was actually 2% contraceptive intake 40 years back, I mean, the whole scenario has changed. Although, most family planning methods, in fact, are for women. But anyway, their change is critical in terms of influencing. And if there's so many misconception, religious barrier affect women's health, especially now I'm speaking about on family planning, but for even many, whatever healthcare, we heard from our one speaker that how actually the community or the family influence women's access to healthcare. So shaping or if the men are aligned that what is happening, and what happens that sometimes that whole discussion about women health is within only women's domain. We as a women sometimes don't even include men. Sorry to say, when I was doing my own PhD on maternal health, I found that men were almost excluded from participating in women's the during the childbirth process. So that means that they don't know many things, that what is happening. Nobody talks. And if, Devashish, as you say, that if you think that this would be, a strong platform for raising awareness, I think for the educated, even for the not educated, even for the community, as you said, about the lower caste or, different minorities, I think we need to have including men within the program, which is quite critical. And I think all the countries are suffering from that. But now that technology is there, I'm sure that many of the people would be able to access information through the technology to self-learn and to also educate others.
Yeah.
Thank you.
Thank you. Thanks so much for that, everyone. And I think we're just left with 4 minutes, so we might just have to skip the last 2 questions that we have from Rupal and Dr. Himali. Please feel free to get in touch with the panelists separately. And before we close off, I would just like to request that if the panelists want to take a minute or two to shed light on what could be the priorities for policy advocacy in your own country contexts or the national healthcare agendas. So if you could just quickly go around, take a minute to just sum this up, that would be very helpful. Maybe Dipti, we can start with you.
Yeah. So if we look into Indian the system policies, what we are actually having, so I feel that there is a lack of life cycle approach. So if the life cycle approach is there, definitely we will be able to sail through the many problems which are cropping in, the which we are able to we are trying to treat in the older ages, and they are cropping in the very early ages, and we are not managing them. So primarily we are trying to have a more of a focus on prevention in management instead of prevention. So if we look at the life cycle approach of a human life, that will be much better than just targeting the policies related to the particular segment of a human life. So my
Right.
take on that, the life cycle approach is the most important part.
Okay. Thanks so much, Dipti. Neha?
Thank you. So close to what Dipti is saying as well, that life cycle approach. And I think the way that I see it is I feel like we just need to start a little bit younger when it comes to, I think if you start doing, even if we talk about just like broader life skills in school and with people who are, when they're very young, just to kind of change how women and men and communities, how they think about their bodies, because I feel like just that relationship and that language also really changes things. So, I think there is a need at the state level to start thinking about that, but then also investing in a lot more information at the pre-service level, service level with healthcare providers and community-based workers on evidence that we already have around this and how the quality of care around gynecological services can be improved.
Yeah. Thanks, Neha. Ramya?
So because I'm in Sri Lanka and we're currently, going through this economic crisis and with cuts to health spending, I would say that more investment in health is very critical at this point, and also considerations to the social determinants of health, including nutrition and things like that, and also more investment in primary health care, including for women's health, and especially focusing on older women and men, considering that our population is aging. And finally, more involvement in people and communities in health. And here I want to, point to the radical potential of self-care, but that how we conceptualize self-care should not be limited to, technologies and family planning, but rather a more kind of holistic approach to self-care. Thank you.
Thanks, Ramya. Dr. Rosana, last to you. Over to you.
I wish that, this is a beginning of our discussion. Think about this is a baseline for our discussion. I know that many of us has done many work in different areas, but if you think about that, whatever we have discussed today, and based on that, if we can do something, not very bigger issues, something small, concrete, that would give some messages to us, to the different countries, that, this is the way we should move. And then I think it would be good. Otherwise, we can do little bit on interventions, and we have discussed many issues, and it's not possible even for any government to do everything at a time. But if you start doing some kind of writing evidence, for me, it's actually evidence is necessary. Otherwise, you cannot talk. That's the problem. If you want to talk, you have to have evidence. You cannot influence the policymakers without having any evidence. That could be quantitative, that could be qualitative, both. So that is necessary, and we have started our discussion. Let's have the whatever discussion we have today, and if we can see that from that we can pick up smaller things and we can go beyond that, what we can do. I think we have to think small, but we can do better later, not at this moment, but think small, do bigger things.
Thank you. Thank you
That's
so
what I
much.
would say.
Thank you so much for that. And I think with that, I'd just like to quickly close by just extending my thanks to all the organizers, the HENI Network, and SRHM, and along with our fantastic set of speakers for such a enriching and a critical conversation today. And these multi-country experiences are incredibly valuable in just highlighting the diverse contexts and the local biologies that shape women's health globally. And I also just want to highlight that this dialogue also paves the way for cross-country learning, especially around practices such as data collection, such as the DHS that we've all discussed today. And finally, I would just like to mention from just an extension of what Dr. Afsana was talking about, that we will be trying to bring this conversation together as an SRHM roundtable publication soon. So please just look out for that. Along with that, SRHM also has the South Asia Regional Hub, and I'll just quickly post the link in the chat today. It's a platform that we can use to continue these critical conversations which are often overlooked. And once again, sincere gratitude to all the speakers and the audience for your engagement and for sharing your invaluable experiences with us. Thank you so much for joining. Thanks, everybody.
You. Thank you.
Thank you.
Thanks.
Thank you, everyone.
Thanks, Emma. Thanks, Sapna. Thanks,
Bye. See you all soon.
Neha and Deepthi, Ramaya.
Thank you so much. It was interesting to listen to all of you.
Yeah. Sapna, thank you so much.
Thank you.
Thank you. Thank you.
Okay.
See you all.
Okay,
Thank
bye.
you.
Bye.
Bye.